Well, here we are, Renee, another episode. How are you today?
Oh, I'm having a great time. How about you? What's going on at the farm today?
Finally winterized the sprayer. It's a great time
Hmm.
of year when you are able to clean everything out, and you know what it means to winterize a
Sure.
sprayer, right, Renee?
Sure. No.
It's where you clean it up, you power wash it, and then you put that pink liquid through it all, the RV antifreeze stuff. So just like winterizing your boat, you have to put all the pink antifreeze stuff in so it doesn't freeze, right? Otherwise, all the hoses freeze up, and so you have to run all that antifreeze material through all the hoses and nozzles and leave it there for the winter, so that way when it freezes this winter, when we put the sprayer into cold storage, it won't hurt it and expand the plastic pieces and break things when we pull it out to use it again next spring. So
All right. So
it's
is
a little,
pink stuff kind of like the antifreeze stuff you put in fuel? You can put it like in your washers, stuff like that, so
you're
that you can
right, right.
clean your windows and all that doesn't freeze like hard in the winter.
Exactly. So that's your farmer maintenance tip. Winterize your sprayer and boats before it gets
Yeah.
cold this fall because that time is coming about quickly.
Yeah, the only thing we really have to worry about is hoses and things of that nature that are attached to pipes and all of that. And we do those things too. So I guess that's winterizing, but I don't have to deal with sprayers. So today we're going to be talking about the ASAM levels of care. And I know Jason's going to start out with explaining what ASAM is because we love our acronyms around here. But we're going to be talking about levels of care for substance use and abuse because there's a lot of things that we can learn from that. And it's much more structured, as we've talked about in the previous podcast, than mental health levels, as an example. And so we're going to talk today about what it is, kind of the history behind it. This is really Jason's forte, so he's going to take it and run today, but really talk about like, how did we get to ASAM levels of care? What does it mean? And then we're going to talk a little bit about some stories about where we've seen this kind of go wrong, where they just don't understand the system and have the wrong things in the wrong place. So to kick us off, Jason, kind of what is ASAM? What does that even mean? And then how does the history, how did we get here?
Yeah, and I think it's important. We talk about September's National Recovery Month. We've been focusing on addiction and substances this month in all of our podcasts. And it seems like we always return to ASAM because we see so oftentimes how it's misused or not used at all in different states across the country. And so the American Society of Addiction Medicine, I know we're trying to get away from acronyms. I know I was just at a conference with you, Renee. And how many acronyms did you have on the list? During one
I
presentation, 45 minutes, you had how many acronyms on the list?
think I was up to between 20 and 25. I just started
Right.
writing down. I was so lost, so lost.
Right. So, we get into this acronym soup business and no one knows what anybody's talking about. And so I challenge us, I know I'm going in a different direction now, but I challenge everyone to think about don't create names just so you have a fun acronym. Let's start using our words
Mm.
to explain what it is that we do. I know it's ridiculous, right?
Yeah,
Um,
I'm not gonna name it, but I was in a two state department meeting with leadership in two state departments, and both of them used their acronyms throughout the meeting. And I know the whole conversation was flying over everybody's heads. You could just see the language flying, and there was only a couple of us in the room who've worked on both sides that probably could interpret most of it, but the rest of them all were smiling and nodding, and I'm like, they have no idea. It was so hard. So back to ASAM. How'd we get here? What's the history of this? Why is it ASAM and who created it? What's
well,
it?
what's great about it, it was created to get us all using the same language, right? It's the most widely used comprehensive set of standards for level of care recommendations, continued service, and care transitions for individuals with addiction and co-occurring conditions, right? So it's the most widely utilized. We get to data. We'll talk to you a little bit about how widely utilized it is because it might surprise you to some extent how much it's used, but how much opportunity there is for states and insurers to even take that farther. We kind of go back in the history bus. ASAM was developed in the early 90s, right? And
Oh,
since
mhm.
then, there's been four revisions of the
Okay.
ASAM criteria. The most recent revision just came out this past summer, which is really exciting. The fourth edition is out. I've got the fourth edition. It's actually holding up my laptop right now, right on top of my DSM-5 TR. And so I would
Mm.
like to say I use those more than just elevation for my laptop. But at the moment, that's what it's being utilized for. The very expensive laptop stand.
which is
However,
way more than an actual laptop stand. True,
yes,
true.
way more than an actual laptop stand. Uh, so I wouldn't suggest that's how you utilize it, right? But what do we use ASAM for, right? It's a holistic treatment planning. It guides clinician, care managers. The criteria is meant to be consistent. So it takes away that evaluator error that we see. Separates us away from that, right? So it really looks at those psychosocial circumstances that help us to identify the appropriate levels of care and look at how do we develop person-centered treatment plans and define the services that need to happen at each level of care. And I think that's what's so exciting from us from a systems perspective, right? It helps us to look at levels of care and be like, what levels of care do we need in the continuum that meet people's needs, right? Where they are in the community where they live. And I think that's what's so exciting about ASAM for me.
Yeah, and what I like about it too is, like you said, it's more clearly delineated than, say, the DSM. I mean, bless those guys' hearts. The DSM is a diagnostic statistical manual for those that are not sure what that means. And the TR is, I think it's some sort of a trial version. It's very strange how they number things. There's like goes from 1 to 2, then there might be a revised vision in there, whatever. And so they named it TR, which means it's probably still in some research stages on some things. But one of the biggest challenges on that side of the mental health world is lots and lots of specific symptoms overlap in the diagnoses. And I was just looking at this recently. Oh, there was a great graphic. I can't remember, but like, say, like the symptom of insomnia, it was like in 13 different diagnoses, or the symptom of, maybe eating too much would be in another 5. And so there's really still a lot of confusion over, if you have this symptomatology and you have these collection of symptoms, what diagnosis is what on the mental health side. And so what I really appreciate about ASAM is it's really tried to think about, like, from a perspective of how much of an issue that you're having. And so it's about levels of care based on need, and more so based from need and like maybe time of use and like the substance being used and things of that nature. So it seems to be a little more clear cut if you need residential or you need outpatient. And so it seems to be like more people be on the same page. The other thing I really appreciate is when you have the system built out with these ASAM levels and you have educated people on what they mean, those two things have to go together. Then when you're talking about it, you're talking about the same language. So to your point, everybody should have the same diagnosis, the same language, and understand that level 1 is X, level 2 is X. And so that, once it's educated and people know. Now we'll tell some stories later where that's not always the case. So what are some of the benefits that you see, because you've worked in this field forever? So what are the benefits that you saw when ASAM came in the 90s, and how did that impact the work that you guys were doing?
Yeah, I mean, I think what you said is so true that we think about how the ASAM levels of care dovetail with the diagnostic criteria that you have in the DSM, right? So it builds upon that diagnostic impressions and diagnosis that are provided to someone and then helps to build what the patient needs moving forward. And so when we look at those 6 dimensions within the ASAM, that really helps then to guide where someone lands in that continuum of care. And so it's not just a philosophical construct, but it really helps us to anchor, is this person receiving the right care at the right time? And is it the least intrusive care that the person needs, right? And those are sometimes really difficult conversations to have. And having a framework to be able to do that is really important. And I think, where this can get difficult sometimes is in a managed care situation, right? Because there can be different perspectives still, even in this type of process to do that. But overall, it's better than not having a framework at all. And as it's evolved, I think the ASAM has just gotten better and better. This last revision did a much better job of looking at the complexity of co-occurring conditions than any previous version has done so far.
Right. And that's a big piece, because there's still two different manuals for two different purposes. And so it's our purview and it's our responsibility to understand how they work together, and to be able to make sure that when you have a person that is dealing with more than one issue at a time, that we get them to the right level of care. And I know, to be fair, when we have some conversations in a minute about some of the stories, part of it is they just didn't maybe have a certain level of care. So they're kind of fudging a bit in these states and calling something this level of care, so that they look like they'd have it at the federal level for a grant purpose or something, or so they've tried to fudge what's reality, so it doesn't really match the definition, so that there's usually a purpose and a reason behind it. And sometimes it's just lack of understanding. And we'll talk about some great ones in a minute. So do we have some data on this about how this works, or how it's been used, or how
Yeah.
it's kind of come out as through history?
Well, and I think that's a perfect transition, right? Is there's a lot of misunderstanding, especially with folks who are trained as mental health clinicians, because they weren't necessarily trained on ASAM or addiction. I can tell you the master's program I went through, we didn't have one class on addiction through that whole
Mhm.
program, other than talking about it when we went over the DSM, right? And so I think, and I won't tell you what version of DSM it was at that time, but it's been a couple versions back, right?
Yeah.
But I think what is important to understand is co-occurring capability. We've been talking about being co-occurring capable. I can tell you for the better part of my career, and we still go
Mhm.
places that aren't co-occurring
Mhm.
capable, who are
Mhm.
still lagging, right? And so I think that's kind of as we think about implementation of the ASAM, as we jump into data, as of 2022, 34 states with Section 1115 waivers to IMD used ASAM. 45 health plans used ASAM criteria to determine medical necessity. That's over 140 million lives covered doing that. 15 states require commercial payers to use ASAM
Mhm.
criteria for medical necessity, right? And the state we live in, Iowa, is one of those states that requires ASAM be utilized for medical necessity. So determining residential level of care, determining detox, right? 24 states require Medicaid plans to use ASAM criteria for the medical necessity, and 13 states use ASAM criteria level care standards to license addiction treatment programs, right? So
Mhm.
it's used widely, but there's, as we think about the number of states, there's a lot of states that don't use
Right.
ASAM. And so things are more like the Wild West, right? In some of those states, because there isn't necessarily a standard, or it's a standard that's hodgepodge together, and that creates conflict and it creates difficulty to access care.
Yeah, and it really creates disparity among people, because then it becomes sometimes more of accessing care because you can afford it. And if you are a person that has means, then you can push to get whatever higher level of care. So when you hear those stories about people going into rehab, and it's like into the Betty Ford type facilities, and those cost a lot of money. And so certain people can afford to do that. So what ASAM does is make it available for all, especially like in those states where it is part of what your criteria are. And it also provides for a state, it provides some cost effectiveness, because when you really do have an objective criteria for a level of care, then you're not just sticking people, everybody who requests X level of care just gets it. Then it has to be a medical necessity, like you mentioned. So that is good. But if you're a person out there that is struggling, sometimes you might not agree with your designation of necessity. You may think I absolutely need more than what they're giving me for my insurance. And so it's kind of a tough spot to be in, but I mean, it is good that people are trying, because it really wasn't working when you just had no criteria. I mean, I've been in this business long enough to know in some of the states I were in was kind of pre-managed care even. And if you think back to the way that was, it really wasn't for any kind of treatment for anything, mental health or substance use, really any kind of criteria. And so some people would get it, some people would not, depended if you could pay for it or if you couldn't, if it was private pay or whatever. And it's just not been the best. So ASAM really is helpful for us states that have been trying. And it's not fixed everything, but it does make a big difference.
It sets it's an understanding so everyone knows what to expect, right? From the family to the patient to the providers to the insurer, that at least there's a set standard that everyone needs to adhere to. And we've seen where that set standard doesn't exist, right, Renee? I mean, we've seen, specifically, specific with mental health conditions, we've seen when there is no standard, how care changes based upon what region you live in, what district you live in, how someone interprets something. We've seen wide examples of that. I think some of the biggest examples we've seen have been jails, right?
Yeah.
We've seen ASAM that's attempted to be applied in jail when someone shouldn't have access to substances, yet
Mhm.
they're still receiving treatment. How does that work, Renee?
Right. Well, I found an interesting story here in the state of Iowa that for a long time they did substance abuse treatment in jail with certified providers. And it was a few years back that they decided that didn't really work because it wasn't a natural setting for people to get treatment. And so you're in a contained setting and trying to get them supposedly treatment, but the criteria for treatment was that they needed to be able to go out and live their life and to be able to stay sober. And so they didn't have that recovery process piece. And I mean, and then not that we don't have drugs and alcohol and things in our facilities, we do some, but it is a lot more likely you can stay sober in an incarcerated situation. So that's not really real life. And so that's part of why some of that has changed as far as what types of treatment they do in incarcerated settings. And the public doesn't understand that. They think there should be all kinds of treatment happening inside. But if you're not living in the real world, some of the treatment that needs to happen is you have to go out and practice being sober and practice staying, mentally sound. And if you don't have that ability, is it really treatment? Because yes, you can learn some foundations and basics, but your rubber meets the road when you go outside and then see what happens next. And so some of those things have been challenging in our state for specifically. So Jason, tell about the story. We won't name a state but it's fun. The state that where the residential level of care, and you could probably tell them exactly which number that is in the ASAM world, was in prison.
Yeah, there was one state where we were helping to figure out how many beds they had across their continuum of care, and we found over half the beds were in prisons and jails. And I had a real hard time understanding that, right? Because
Right.
kind of like you just said, there does need to be some levels of treatment that happen in jail and prisons, but it looks very different. And it doesn't really fit the continuum that we're talking about with ASAM. And so, as we think about utilizing ASAM, states have gotten confused sometimes, and then it ends up becoming something that it's not. And then it looks like a state has a lot more of something that they actually don't have. And so, when we think about residential beds being prison beds, that really isn't accessible to the general public. That's not actually what a continuum of care looks like. And then that's not what a path to treatment looks like as people are looking for recovery. Just one example, we've seen similar things in other states as well as we've continued our journey of traveling around. And that's part of why it's so important to look at ASAM and understand ASAM and understand how it's written into rule and how it's implemented at all stages across the continuum of care.
Yep. And this just prompted a memory of one of my all-time
Yeah.
favorite stories when I was trying to redesign the mental health system. And for the reason why was my poor little sheriff down in whatever southeastern Iowa county, who came to me that said they use their mental health funds for a new police car so somebody could just sober up in the back. And that hurt my heart so much, but that was like some of the gasoline that kept my fire going to keep pushing toward reform. Because I was like, no, no, that is so inappropriate that you just said that. And they weren't really kidding. I mean, they were really, that's what they used their mental health dollars for, was a police car. And I was like, this is absolutely not the type of treatment that we need for folks that need sobriety. Is they may need a safe ride to a location to get detox. This may be true, but that's just a small piece. There hopefully is somebody to catch and help them and with medications. We're going to be talking about that here in an upcoming episode
Right.
of, being able to help them get to sober. And unfortunately, he wasn't joking. It was a very serious conversation. And it just really bothered me because I'm like, that is absolutely not what we're trying to do here. And so, we've talked about that, but jails unfortunately become the place where people have to sober up. They get dropped off there and there's really no detox options for them. And that could be a
Well,
very challenging
mhm.
situation.
And I think you bring up a good point, right? We know in some urban areas, I just read about it, last month about sobering centers.
Mhm.
That there's going to be a new sobering center, in Des Moines, in the state where we're at. There's a sobering center across the state, but that's not accessible to rural folks, right? And so then we see this utilizing jails, and the legal system as opposed to an alternative or a diversion, right? And so it's thinking about how do we create equitable access across the entire state that some folks get legal charges and some folks get dropped off at a sobering center. That creates big disparities. And I don't think we have good answers for that today.
No, and I just read an article in one of our recent papers about the homeless situation in our larger communities, and those mayors are accusing other people of dropping their folks off into the bigger community to increase the numbers of folks that are on the streets. And if we have a sobering center, boy, I could start seeing
Mhm.
how that not a long leap before other people are going to start putting folks on a bus and be like, hey, go there to the sobering
Mhm.
center and good luck to you. And so there's
Mhm.
already a challenge just with folks that are not housed. And so can you imagine when you bring a sobering
Mhm.
center? I don't think that everybody has thought through, because there's no lines or boundaries in that. And that was always what was wrong with the mental health system and the behavioral health system, was we had these lines or boundaries as if somebody's going to know exactly what little side of a line they live on, and that's where they're going to show up for treatment. That just doesn't work. It doesn't make any sense. And I know it was due to funding and all the things, but when you're a real person, they're not going to be like, huh, I live on this side of this county line, so therefore I go to here to get payment for treatment. That's not reality. So the same thing is with this. If you have the sobering center, it will draw people in that need the help. And then there'll be a big fight about, who's responsible and how dare other communities send people to it. And that's, you see that in every state. That we talked about this when we've done our work up in Minnesota. A lot of the beds, they did a very big project to put 16 beds for their state institutions in all the regions, but they see that the most people in them, right, are from the Twin Cities area that end up filling up all of those spaces. So even if you're from one of those rural spots, yes, you have the hospital there, but you may not get that spot. You have to move across the state. And that's just how it works with population in general. We had that same conversation in North Dakota with Fargo and people coming in from Minnesota or, wherever the populated areas are. So it's always a challenge because that's where the resources are. So people with needs end up there because they know they're more likely to get help. And so we just have to be thinking about that. And when we come to this ASAM conversation, are those folks ready to understand what levels of care those are? And when you're creating something like a sobering center, which is none of these levels of care, that makes it very challenging to just define what it is and what kind of treatment you're going to get.
Well, and I think it kind of comes to our last point of this segment is it drives people, well-meaning people, to provide services beyond the scope of what they're designed for. And so as we look at the levels of care and the continuum that should exist, we see this all of the time, that well-meaning people provide beyond what they're capable of being able to do to serve someone adequately, just because they believe a perceived absence of anyone else available to do it, which then people who should be doing it just step back instead of stepping up. And I think that is profoundly what's wrong with our systems today in many of the states we do work in, is because people over deliver thinking they're doing well and they do more damage in the long run. We've seen this over and over again in states that we go to, that well-meaning people think they're trying to fill a gap, and they end up doing more harm to the people that they're serving.
That's right. That's a really good point. And so thinking about this, if you're a provider listening and you don't really understand ASAM levels of care, this may not be the space for you, or you just need to really buckle down and get some more education, especially when our state and states nearby are using this as medical necessity criteria. That means you have to have an understanding of how it works in order to really make it happen. And creating, like we're just saying, a system outside of this levels of care, that already means that our insurance companies and paying for it isn't a choice, right? So now we've created this new sobering center where none of the insurance is going to ever work there because they use a criteria system and this center doesn't. And so now you've already got yourself in a spot of like, who's going to pay for it?
And insurance is never going to pay for it when it's outside of the scope of the ASAM criteria. And so, I'm writing a report right now for a local state legislature, and I'm saying you have to design the continuum of care around what Medicaid pays for, period. Get
if you wanted to fund it, right? And then you can't complain later when the state doesn't help you or Medicaid doesn't help you or whatever else. Because if you designed it so none of those criteria fall into what you're doing, you get what you get. And then later they absolutely throw fits and you're like, but you created it not to fit. It doesn't work.
Any recommendation we make is going to be a fundable, operational recommendation. I don't make recommendations that aren't fundable and operational because it won't happen, and it certainly won't be consistent, and it certainly won't be equitable. Don't get me started, Renee.
Oh man, good place to end the conversation. So the recovering politician self-care policy of the week focuses on the weather's changing. And I don't know about you, Jason, but I have to kind of start switching up some of my workout plans. My pool just recently closed outdoors, and so I can't do the outdoor stuff quite as much, especially in the Midwest. I don't have access to some of that. And so if I'm not careful, it's easy just to stop doing what I was doing because, well, that's closed now. And for me, I have to actually be thinking about, okay, it's time to, what else could I do? What else do I want to do? What do I want to do in the fall? It opens up other opportunities, maybe things that were too hot to do in the summer, you can do now because it's still kind of nice outside. Or, start thinking about like switching it up. Because if I don't, too many days, weeks pass, and then I'm doing nothing and I'm a big couch potato again. And I don't need to go into the fall and holiday season starting out as a couch potato. That's just not good. So it's like thinking about new things. So that's what I'm doing. I'm starting to think about, okay, how could I switch things up? So Jason, what about you? I know you like to run. Do you get to run more in the fall, or now you're sitting in cabs in the, I don't know, are you getting to actually
Well,
move at all
I
or what?
get I get more exercise because we've got a different combine this year, so it's a little farther up the ladder into the combine, and I've got to check that new bin. So it's a steps workout every time I've got to climb, 3 stories up to look into that new grain bin. So I'm just changed up my stuff into, just more of a cross training workout here for the fall until I get back to running again.
That makes sense. So today, everybody, we went back and looked at ASAM and what is it, and talked about the history of how we got here, some of the data of who uses it and where and how it works, and then talked about some of the places where it's just not working very well. And if you're not really sure what it means, we're going to have some notes for you in the show notes where you can go and look, learn a little bit more about ASAM and how it is a great tool to help us actually make sense out of what we're doing for mental health and for behavioral health and substance use care. So thanks, everybody. We'll see you again next time.